Good morning, good afternoon, and good evening. Welcome to ICAP Grand Rounds. We are going to just allow another minute or two for a few more participants to join, and then we'll be starting. So please stay with us. Okay, I think we'll get started. Again, good morning, good afternoon, and good evening, and welcome to ICAP Grand Rounds. I'm Dr. Jessica Justman, ICAP's Senior Technical Director, and I'm very pleased to be starting us off on our Grand Rounds today, which is going to talk about Mpox. I'm going to provide our welcome and introduce our speakers. And then I just will give everybody a reminder here to put questions to the panelists in the Q&A box. And also to mention that the webinar is going to be recorded and the slides will be posted on the ICAP website as indicated here on the slide. So last month, the World Health Organization declared that the resurgence of Mpox across the African region constituted a public health emergency. Mpox cases in the African region have now exceeded 30,000 cases this year alone, and the highest number of cases have been in the Democratic Republic of Congo, or DRC, the outbreaks epicenter. As outbreaks of different clades or types of Mpox continue to occur across Africa with different modes of transmission and different levels of risk, a coordinated international response to manage the spread of the virus is clearly needed. Today, we're going to have presentations from the Africa Centers for Disease Control and Prevention and from the World Health Organization Africa Office, and we'll explore updates on the Mpox epidemic in the African region, including continent-wide responses. So our first speaker will be Dr. Ngashi Ngongo. Dr. Ngongo is a public health physician with over 3 years of experience. He currently serves as Chief of Staff and Head of the Executive Office at Africa CDC. He's also founder of the International Center for Health System Strengthening in the US. He previously served as team leader of the UNICEF Global Malaria Program in New York, team leader of UNICEF's Ebola health response in Liberia and the DRC, in addition to many other roles. He has served on several international boards, including Medicines for Malaria Venture, and he's a lecturer at the School of Public Health in the University of Lubumbashi in the DRC. Dr. Ngongo, please. We are ready to hear from you. Thank you.
Yes, thank you very much, Jessica. Thanks to ICAP and the New York City Pandemic Response Institute for inviting us to be part of this sharing of the voices from the field. I have the pleasure to share with you the latest Mpox epidemiological updates from the current ongoing response. Next. Let me just start here by saying that Mpox is rapidly spreading on the continent. If you remember that in July 2022, WHO declared Mpox as a public health emergency of international concern, and then declared also the end of it in May 2023. But if you look at this graph, you see that even during the global public health emergency, the cases in Africa were still on the upward trend. And they have continued doing so until in 2024, when in August, then Africa CDC declared Mpox a public health emergency of continental security. on the 13th, and one day later, Dr. Tedros also declared it a public health emergency of international concern. But you notice one thing, when the declaration was made in July 22, 2022, there were 5 dates. But when the declaration was made this year, we had 541 dates. That represent 100 times, I think, the number of dates that motivated the declaration in 2022. Next. Now, at the beginning of the year, we started with 9 countries that were affected in West and Central Africa. Now, by 21 September 2024, we've reached 15 countries that are affected in all 5 regions of the African Union. I think just to see the rapid spread of the epidemic on the continent. Next. Now, when you look at the number of cases, Jessica just mentioned that we've now exceeded by week 37, 32,010 cases that were notified, of which 6,439 confirmed and 840 deaths. Now, for the AP week 37 alone, we had 2,652 new cases. That's a slight decrease of 4.8% from the previous week. 434 new cases that were confirmed. That's an increase of about 6% from the previous week. But in terms of the distribution, I think it is still dominated by males. That makes 63% of all cases, and children below 15 that have a higher portion, about 41%. But some of the major challenges that we are facing is the testing rate, as you can see, which stands now at about 49%, meaning that 51% of those that meet the case definition still don't have access to testing to confirm their status. And with the risk that if there's no confirmation of status, that means that those people are still at the community out there spreading the infection. And also on the other side is the positivity rate, which is still at 41%. That also brings the question of what else is happening if you have almost 60% of the cases meeting the definition but testing negative for Mpox. Is it the quality of the samples, or is it that there are other diseases that are also spreading at the same time? Next. Now, when you look at the distribution of different clades, I think we have clade 1B, which is the new variant that started in Eastern DRC and now has spread to Burundi, Kenya, Uganda, and Rwanda. And then in the DRC in particular, we had the 1A that has been there since 2022, and then the new variant, which is 1B in the east. But in Kinshasa right now, both clades are now circulating, I think 1A and 1B. And we can also see that clade 2 continues in West Africa, in the north in Morocco, and also in Southern Africa. And most importantly is that when you compare then the period from January to September 2022 with January to September 2024, you see a huge increase, about 177% in the number of notified cases and 38.5% in the number of deaths. I think those are some of the reasons that motivated the double declaration by Africa CDC and WHO. Next. Now, when you look at the countries with active transmission in the year 2024, as of September 17, we have 6 countries that are newly affected since July. That's Burundi, Rwanda, Uganda, Kenya, Guinea, and Gabon. We have 5 countries that are newly re-affected since July also. That is Cote d'Ivoire, Liberia, Congo, Cameroon, and Morocco. And we have 4 countries that have been there, I think, since last year. That is CAR, DRC, Nigeria, and South Africa. Next. Now, when you look at just the last 4 weeks, we noticed that about 8 of the 15 countries that are listed there reported a new confirmed case. That's how the situation really stands. But Congo, it's now more than 4 weeks that Congo hasn't reported a confirmed case. We also have Gabon, Kenya, and Guinea that haven't reported any new confirmed case for over 3 weeks now. And also Cameroon, South Africa, and Morocco, which haven't reported a new case for the over the last two weeks. Next. Now, let's dive a little bit into some of these countries. I think the ones where the highest burden of this epidemic is. Let's start with the DRC. The DRC alone, out of the 32,000 notified cases that have been reported now in Africa, we have 26,000 of them just coming from the DRC. 5,599 confirmed cases from the DRC and 833 deaths from the DRC. I said that's really where the highest burden of this is happening. And when you see the epicenter, you see that the cases are still on the upward trend. And the red also mentioned the confirmation, that the confirmation is still low for the reason that is related to the testing rate in the DRC, which is below 50% until now. Now look at the week 37, AP week 37, DRC notified 1,775 cases, of 232 were confirmed cases, and there were 16 deaths during that week. And the distribution since the beginning of the year, once again, as the general picture of Africa, we have males representing 54%, children under 15 representing 35%, and the same challenges remain. Testing rate is stand now at 44%. Just to say that there have been great effort really in the DRC. In April, when we had that international conference on Mpox, testing rate was around 12%. I think it is since then that we have really all the partners, WHO, Africa, CC, and all the key partners working together have been supporting them to reach 44, and the great more effort are there to really help them get to the target of 80% that they have set up in the national plan. The test positivity rate stands now at 53%, and some of the work that was done at ENRB with Professor Muyembe is now showing that some of the negatives in children is because of measles, and in the adult population because of herpes also. Now, the entire country is affected. All the 26 provinces of DRC are affected, but the greatest burden is reported in 3 provinces. That's Equateur on the east, Sud Kivu on the Equateur on the west, Sud Kivu on the east, and then Sankuru at the center of the country. Next. Now, something very important is the surveillance of Mpox in DRC, which really shows that we are still very far from controlling this outbreak in the DRC. 68% of the confirmed cases have got no link to a contact. I think that only 32%. What does that mean? Is that 2/3 of all the confirmed cases come outside the control chain of transmission. That's why we don't know really what is happening. Now, that is a reflection of the major weaknesses in surveillance. I think that have been reported. And we are really working together to strengthen the community-based surveillance for early detection with active case search in the DRC and all the other countries as well. Next. Now, when you look at the cumulative incidence by age group, just you'll see that at national level, on the left you have the confirmed cases, on the right you have all the notified cases. That you'll see that when you look at the notified cases, the incidence is higher among children, across the board. But when you look at the confirmed cases, the incidence in children is comparable to what you have in the other age group. Now, what does that mean? Exactly what we saw with the positivity rate. That many of these children meet the case definition, but they don't suffer from Mpox. They suffer from something else. I think that's what the testing conducted by ENRB is now also giving some initial data that it might be that there's measles on one side, but also Mpox. The same situation in the Kivu, where we see there, again, the cases suspected, or these are, we have a high incidence in children, but when it comes to the confirmation, the incidence is much lower, I think for the reason that I've just mentioned. Meaning that Mpox is an opportunity then to also strengthen the surveillance and pick up other diseases that have been circulating with no with the weak surveillance not being able to pick them up and respond adequately. Next. Now, if we dive into Sud Kivu, which is now the epicenter of the outbreak among the provinces in the DRC, we see that by the week 37, there has been a continued extension of the epidemic to new health zones. And on week 37, 5 new health zones that have been affected in the northern part of the province, now bringing the total number to 12 health zones that are now affected by the Mpox outbreak. But most importantly, you know that the eastern part of DRC, the Sud Kivu and North Kivu, that's where we also have the armed groups and the armed conflict that are going on. 23 confirmed cases have been also identified from the IDP side. That's the reason why I think as part of the response, refugees and IDPs have been also included as one of the vulnerable groups to be protected because of the spread of the outbreak in those settings. Next. Now, in the same Sud Kivu, I think there's a very interesting transmission dynamics that you can see on the map. You have different transmission modes that are interacting at the same time. We have the in red, which is this part that you see in the center and down south. It is a predominantly an adult epidemic. That's through sexual networks that are more associated with the mines, I think, that are in that part of the province, in the health zones of Kamituga, Kitutu, and Kimbilulende. But at the same time, we also have another picture of the predominantly epidemic through the normal household and community transmission. I think that you can see toward the north in blue in the health zones of Bagira Kasha and Walungu. But at the same time, you can also see the children here toward the north. You see an epidemic that is predominant in children through household and community transmission. And that is also where there is some anecdotal evidence of transmission in the schools, because after the reopening of the school, we see an increase of cases in those. That is in the health zones of Kalehe, Mitimuresa, and Nyangezi. And finally, there's also a picture in Uvira down toward the eastern, where in green there, where we see the combination of adult and children's epidemic, which is happening predominantly through household and community transmission in the Uvira health zones. Next. Now, just going into Uvira, the one I've just spoken, if you see the confirmed cases by profession, you see that in there, because they combine the adult and children, you see that students still really account for a good share of the cases that are reported there. I think that's why I think there's a greater focus on really understanding what is happening in the schools on one side, but also ensuring that there is surveillance and the IPC that is strengthened in the schools to protect the children. And on the right, you see the distribution by gender that is still slightly dominated by males compared to the females. Next. Now, what is the latest is really the concerns about the spread in Kinshasa and the capital city because of the heavy crowding. It's a big city of about 15 million. If you see there, as I said, that Kinshasa is the only province in DRC where we have seen both clade 1A and 1B circulating at the same time. That at the beginning of the year, it was clade 1A. I think that has been circulating. And you can see the epic curve there. I think the spread wasn't really very significant. But from the 27th week, the clade 1B was also detected in Kinshasa, and you can see that from 27th week to the 37th week, you see now the increase in the number of cases. I think this is a place where the mobility is very high, the crowding that really facilitates the spread of the disease. The reason why there's now a greater emphasis really to strengthen the response in the capital city of Kinshasa. Next. Now, when we look at the situation in Burundi, we see that Burundi has now notified about 1,982 cases, of which 564 have been confirmed. But the good news about Burundi, something really to learn about, is that until now, they still have 0 deaths. We'd like to understand really what are the factors that are contributing here compared to just next to DRC where mortality is high. And during the week April 37, 493 cases that were notified, 179 cases confirmed. And since the beginning, in terms of the distribution, also 53% are males. Children make slightly over 50% in Burundi. The testing rate is at 66%, much better than DRC, which is still below 50%, but we still have 1/3 of the cases that are not investigated and then facilitating the continued spread. The problem is the positivity rate. It's much lower in Burundi, and we still need to understand, is it the quality of the specimens or it is then the other underlying diseases that are being also picked up because of the opportunity of Mpox. The clade that is circulating is the same in on the eastern part of on the east of the DRC is clade 1B. Out of the 49 districts in Burundi, 30 are already affected, including 3 districts in the capital city in Bujumbura, which now account for 62% of all cases. Next. And in Bujumbura, also, when you look really from the beginning, there's a widespread of cases across the country, but mostly on the eastern part, in the center, and on the south. As we see in the north, there are still many districts in the north that are not yet affected, and also on the eastern part of the country. Next. Now, in Central African Republic, I think they have notified 319 cases, 54 that are confirmed with only 1 death. Just remember that Central African Republic is dealing with clade 1A. Now, when you look at the number of cases, the pattern is still on the increase. The confirmation rate is low, just like in other countries. During the AP week of 37, 22 cases were notified, 5 confirmed cases, and 0 deaths. And since the beginning of the year, the distribution keeps maintained the same pattern in other countries. 64% are males, 47% are children below the age of 15. Burundi is one of the few countries that are, Central African Republic is one of the few countries that are doing very well on testing. It's 100% testing, but the issue there is the positivity rate, which is among the lowest. I think we also need to understand what might be contributing to that as well. Next. And in CAR, what we can also say that it's now about 7 districts that have been affected, have active transmission. And since the beginning of the year, 14 districts that have reported at least 1 notified case, which is also really the spread that you can see mainly on the southern part of the country and on the eastern part of the country. I think the north and the west are somehow still silent. What does that mean? Is it because there are no cases, or it is because the surveillance is not working as it is in many other parts of the country? Next. And finally, just to say that the overall picture that we see is that the number of cases continue to increase in Africa with mixed modes of transmission. And it is true because of all those challenges related to surveillance and testing. We all agree that what we see is just the tip of the iceberg. I think the more we improve on the surveillance, the more we improve on the testing rate, I think we'll get closer to a real picture of the Mpox outbreak in Africa. Transmission dynamics are still not well understood. I think there is need to continue with the investigations, with the contact tracing, but very importantly also with research. But most importantly is that where we are seeing that we are not yet really getting this epidemic under control for those huge challenges. It is really time to intensify the response, focusing on the key pillars, ensure that we move from passive to active surveillance. We intensify the contact tracing through community health workers. We intensify risk communication and community engagement. We look at the IPC, both in health facilities and communities. When we talk about communities, also in schools. We are now introducing targeted vaccination. I think we're expecting today the announcement by President Biden of another 1 million doses of vaccines that are donated to Africa. More good news. And finally, is the care that is also extremely important to lower the case fatality rate. Thank you very much.
Well, Dr. Ngongo, thank you very much. That was really just a wonderful overview of the situation. Very, very informative. So that was great. We're now going to go to our second speaker, Dr. Fiona Braca, who is with World Health Organization's Regional Office for Africa, or AFRO, WHO AFRO. Dr. Braca is the Emergency Response Manager for WHO AFRO, based in Brazzaville, Congo. And she leads the regional response operations for acute and protracted health emergencies, including disease outbreaks and humanitarian crises. Her role also entails the coordination of AFRO support to countries to strengthen their local capacities for emergency response through the AFRO EPR Surge Initiative. She has 2 decades of national and international experience with the World Health Organization. Previously, she served in different roles in Nigeria, Ethiopia, and Uganda, where she led WHO's efforts to eradicate wild polio virus and supported national governments to strengthen their vaccination programs. Dr. Braca.
Thank you very much, and good morning, good afternoon, good evening to everybody. I would also like to extend my appreciation to ICAP for inviting us to be part of this Grand Rounds, along with my colleague from Africa CDC. And I will be updating you on how the response is going in the front line through a regionally coordinated response. And we'll share some of the challenges that we are experiencing as we progress. I'd like to start off by saying it's a partnership effort with member states and several partners, and we are actually pleased to see the increasing interest in Mpox globally. This is a disease that has been long-standing in Africa, but was neglected for a while. So we are very happy to see this interest. Next slide. So it is a globally coordinated effort, as I said, with member states in the lead, but with partners as well. And following the concerning surge in cases, as has been shown by Dr. Ngashi earlier this year, the WHO Director General declared the Mpox outbreak a public health emergency of international concern. This declaration happened on the 14th of August. And as you are also aware, Africa CDC did declare as well Mpox as a public health concern, public health emergency of continental security. So what is a public health emergency of international concern? It's essentially an extraordinary event which is determined based on risk, the public health risk to countries through international spread. And it's also based on the need for a coordinated international response. Historically, there have been 7 public health emergencies of international concern so far. You'll recall H1N1, we had Ebola in West Africa and in the DRC, polio virus outbreaks. We've had Zika, and you'll also recall more recently COVID-19, which was in the similar situation. And this is the second time that Mpox is being declared a public health emergency of international concern. The first one was 2 years ago in 2022. So following that declaration in August, there were temporary recommendations that have been issued to countries that are experiencing a surge in cases. And these are centered around enhancing or accelerating a key set of interventions in those countries to try and quickly bring the outbreak under control. Next. So there is a global strategic preparedness and response plan that has been developed and released publicly. It's available on the websites and on that link. The goal is really to see how to stop outbreaks of human-to-human transmission, and it's centered around 5 interconnected systems we refer to usually as the 5 Cs. These are linked to the global architecture for health emergency preparedness and response, and it's building on the lessons that we learned from COVID about what the world needs to do better for future pandemics. So we are building on those lessons, and they center around ensuring strong surveillance systems that are preferably integrated within the health systems for surveillance, case detection, investigation, laboratory capacities. Then there is the aspects of community protection. Here we have a range of interventions at the community level, trying to ensure we have proactive risk communication and community engagement, and a set of interventions that I'll elaborate on shortly. We also have safe and scalable care, looking at case management and how we protect health workers that are in the front line, protect people that are caring for loved ones that have Mpox in this particular context. We also have access to countermeasures, so the scaling up access to vaccines, to therapeutics and diagnostics, and then ensuring we have strong coordination and leadership and governance structures, which are very important for control of these epidemics or pandemics. And finally, the last one was added on so that we don't forget the importance of research and development in public health response, recognizing we do not know everything about these diseases, and we need to keep advancing in research, in understanding of disease, in the tools that we use to control disease. So this is the sort of global approach. And next slide, we have aligned this at the continental level. We have joined hands together, Africa CDC and WHO on the continent to articulate an Mpox continental preparedness and response plan for Africa. This approach is to promote alignment, harmonization, under a one team, one plan, one budget, one M&E framework approach. It is the first time that we are doing this. We are continuing to learn every day, but it helps a lot to maximize on resources that are available, to avoid duplication, ensure that there is information sharing, and that we can work more efficiently to respond to these outbreaks. We have set up a continental incident management support team based in Kinshasa, and there are 10 pillars of the response that have been activated under that IMST, and the plan is costed, and resources are being mobilized to implement that plan. We are pleased with the recent announcement from the Pandemic Fund last week of $128 million that's going towards country response in targeted countries, as well as regional preparedness activities. Entities such as Gavi and several others, the private sector, are also expressing interest to support, and we are really pleased with the attention that this collaborative effort has attracted. Next. So the concept of operations in this plan is that we group the countries based on risk, looking at those that are experiencing sustained human-to-human transmission, that is the category 1 countries. And then we have those that are having sporadic human cases, or those that have been assessed as having endemic zoonotic reservoirs for Mpox. Then we have those that are high risk by virtue of being in proximity to those countries that are having sustained transmission, and then the rest of the countries fall into category 4. We then tailor interventions based on this categorization. And as the data has shown, we have countries like DRC and Burundi that account for almost 97% of all the cases that we are seeing this year. And then you have CAR, you have Uganda, Cote d'Ivoire, Nigeria, South Africa also having reported local transmission. And so the priority interventions are defined, but also to say that these countries, we have worked with them to submit operational plans. So it was a bottom-up sort of planning and costing process. So there are plans from the active outbreak countries. Currently, 14 of them have active outbreaks, but we have 17 that have reported for the WHO Afro region this year. Next. Dr. Ngashi has highlighted the complexities of this response in the African region. We are dealing with concurrent modes of transmission, so zoonotic to human transmission, human-to-human transmission through physical contact, human-to-human transmission through sexual transmission. You'll find that there you can have these concurrent modes of transmission in the same country, in the same province, as he showed in South Kivu. That complicates the response. And at the same time, we still don't understand the transmission dynamics because overall the surveillance and the investigation capacities are not optimal. So we do not clearly understand some of these chains. But with the information we have, I think it's been very useful, and we are encouraging the countries to strengthen their capacities and the investigations of these cases to better understand. We've seen different age groups in addition to different demographics. So we have children, we have adults, we have sex workers, we have heterosexual persons, we have men sleeping with men, different groups of people, and trying to tailor, first of all, understand the dynamic there, tailor the interventions. All this adds to the complexity. Low testing and sequencing capacity also, we've seen the statistics. And then for DRC, that is epicenter, we are also dealing with conflict and insecurity in the eastern part of the country. And they are also dealing with multiple concurrent outbreaks. We have measles outbreaks, we have cholera, we have circulating vaccine-derived poliovirus outbreaks, we have humanitarian situations. All these are stretching the already fragile health systems, and that complicates the response further. Next. However, all hope is not lost. We have the tools and the evidence that these outbreaks can be controlled using public health and social measures. If these are implemented well, they can be able to contain the outbreaks. But you know, we see this common idea that you must have vaccines and it will be the magic bullet. But our message is that it's a combination of a set of interventions that will help us to break these chains of transmission. And we saw that with COVID as well. These public health measures that include early detection, making sure that any person who's suspect or confirmed should be isolated, that we do the intensive in-depth investigation, the contact tracing, implement appropriate infection prevention measures at the health facility level, community and household levels, that our health workers are protected, they have the appropriate personal protective equipment when they're handling suspect or confirmed cases, and that also communities are involved in containing the spread. These set of measures can be able to manage the spread of Mpox. Next. So I will touch on a couple of them. One of them is the surveillance, the timely detection and investigation. This is the first critical step, and we have worked with countries to integrate Mpox as a notifiable disease within the integrated disease surveillance and response framework, so that there are mechanisms for notifying, immediately reporting any suspect case, so that it triggers a chain of processes, including the investigation. And there are different approaches, the event-based surveillance, but also we are trying to strengthen the community level processes, because many times we realize not all cases report to a facility, so we must have community level networks, and we're working with UNICEF, with IFRC, to use their structures of community volunteers to be able to detect and to refer or report to the nearest facility. We encourage regular and timely reporting. All countries are under the international health regulations are expected to immediately notify of Mpox cases, particularly those that have a history of travel. It's important that they are notified immediately and that there is some collaboration in terms of the investigation. There are guidelines for the countries on surveillance, on case investigation, testing, and so on. These have been provided to the countries. And we're also working with the countries to strengthen their capacities for timely diagnosis, including at the peripheral level. Then the genetic characterization, extremely important part of building on our understanding and tracking the spread of different clades, also very important for the overall response. Next. Next. So when it comes to the diagnosis as part of the collaborative surveillance and detection, anyone meeting the case definition of a suspect or a probable case is recommended to be tested. And the recommended specimen is the skin lesion material. There are PCR tests that are available. And we also encourage sequencing to help interpret the disease epidemiology and sharing of the sequencing data so that this is readily available and we can piece information together to understand the patterns. There are efforts to decentralize the testing. So there are points of care, molecular tests, and also gene expert tests that have been validated. For instance, in the DRC, they are helping to decentralize Mpox testing. But overall, as Dr. Ngashi said, the testing is still very low, only 44% in our epicenter country, and that remains an area that needs to be improved. Next. We talked about community protection. This is achieved through a broad range of interventions. We promote this integrated package, recognizing there is not one intervention that can work to break the chains of transmission. So it's important that the countries implement it as a package. And this includes the community engagement, the understanding of the animal to human transmission and trying to prevent that, the IPC, infection prevention and control. I've mentioned the public health and social measures, and overall promoting a multi-sectoral approach, because this is a disease that cuts across different spheres. So this is the schematic of all these interventions, again, emphasizing we need to implement a package. Next. There have been lots of concerns about community perception, community awareness, rumors, stigma. It's a very important aspect of the response that unless we address those, that our interventions will not be accepted. We've learned a lot from past outbreaks like Ebola, like COVID, the importance of carrying communities along. So there are different surveys that are periodically done to assess these acceptance or perception levels. We did a global message testing campaign in 14 countries across 5 regions. It showed that 46% of the respondents from the African region, the countries that represented us in that survey, they have heard about Mpox. So less than 50% have heard about Mpox, and 40% reported to have been concerned about it. There have been also studies in the DRC. They have demonstrated that the need for enhanced community engagement, particularly before vaccination of targeted groups. These were sort of acceptance surveys. And overall, we still have a lot to do around targeting and tailoring our messaging to address these concerns and to address the different groups that we are seeing affected in this response. I'll say just a quick note on the access to countermeasures, specifically vaccines. Next slide. This is one piece of the response. Next slide, please. There are 3 licensed vaccines available. These have started to trickle to the continent. We have seen the first doses arriving in DR Congo. We're expecting more. And Gavi and UNICEF have also put out a call started a process to finance and procure vaccines. One product has been qualified, the MVABN, and this has opened the door for having more access to these vaccines from a manufacturing and access point of view. I think I'll just end. Final slide. For the interest of time, I'll skip this, but just mention that research is well integrated into the response. As I conclude, just to say that Mpox outbreaks can be controlled. We have seen these outbreaks controlled before. The global outbreak in 2022, with more than 100,000 cases, 117 countries, we were able to control it in a number of those countries. Coordination and collaboration, extremely important across continents, countries, partners, and stakeholders. We need to be more proactive around preparedness and building resilient health systems to tackle these outbreaks. And ultimately, the communities that we are serving need to be part of the response. We have to target the interventions tailored to meet their needs. And we are also continuing to promote the use of science, the use of evidence to guide these interventions to be more effective in how we can rapidly contain these outbreaks. Thank you so much for your attention and, again, your interest in this area of public health. Thank you so much.
Okay, that was wonderful, Dr. Braca. Thank you so much. We do have some questions that have come in, actually I have a question or two myself, but I will start with some of the questions that have come in from our audience. There's one question for Dr. Ngongo about the suspected school-based transmissions, whether the thought is that this is through close contact or is there any evidence for aerosol transmission? Dr. Ngongo, any brief reactions to that?
Yeah, thank you very much, Jessica. I think it is to believe that it is through physical contact. I think that's the reason why the measures now are the one to strengthen the hand washing in schools so that we can now start moving toward permanent hand washing facilities in schools, but at the same time also train the teachers to in surveillance so that they can pick those children early and take them out of schools.
Great, thank you. Then there are a couple of questions that I think are suitable for Dr. Braca, and I'm going to put them together for you. One is asking about the recent WHO approval of the MVA-BN, a Bavarian vaccine that you just mentioned. And I guess really the question is, do individual countries, do their medicines agencies need to approve these vaccines on an individual basis, or are you aware of whether once WHO approves, that sort of opens the door? So any comments on sort of the vaccine approval process? And the second question is standardization of case definitions across countries. Has that been going well? Does that have delays to it that need attention?
Okay, thank you very much. So for the vaccine processes, yes, so it's currently just the MVA-BN that's been pre-qualified. We are hoping that the LC16, which is the Japanese vaccine, will also receive the pre-qualification. I think that will allow us to have more products, and particularly also because LC16 is the one that's recommended for children. So previously, without the pre-qualification process, the countries needed to go through the emergency use listing procedures. So they needed to go through the licensing, the processes at country level with their national regulatory authorities to ensure that all aspects are taken care of. Now, with the pre-qualification by WHO, it cuts the processes down significantly. Most countries go by the pre-qualification process of WHO, and it also allows international entities like Gavi, like UNICEF, to also proceed with global procurement. So what would still be required by the countries, like any other medicine or drug, is that they also have to go through a licensing process. But this is a much shorter process because of the WHO pre-qualification that has been granted. In terms of standardization of case definitions, yes, there is an effort to do that. There is a guidance document on one of the links that I have shared, trying to define those suspect, probable, confirmed cases, standardizing that across the countries. And we go through that orientation with the countries to ensure that this is standardized. As I said, it is now part of the integrated disease surveillance and response notifiable diseases. So it is standardized also at country level.
Great. Okay. Now I'm going to again put together, there are two clinical questions, and either of you can decide who would like to take it. The first is from Tanzanian clinician who wants more information about how to manage potentially fatal complications, and is asking what specifically is at the root of these potentially fatal infections. Is it primarily a sepsis syndrome? Is it wounds becoming super infected? I think, for clinicians, I think they want an idea of what to be prepared for. And then a second, more clinical question is about the LC16 vaccine, and asking about the age range that's been approved for. Can that be used for children, and if so, to what age? So you should speak up if you're ready to answer these more clinically oriented questions.
Yes, perhaps I can start. I think Fiona can add. I think on the clinical from the colleague from Tanzania, all starts from the bacterial infections of the skin. That can start already from the skin itself, can lead up to abscesses, but then from there it can spread to the brain and cause encephalitis. It can spread to the heart and cause myocarditis. It can spread to the lungs and cause pneumonia. It can also spread to the eyes as well. I think all start from bacterial infections of the skin and the spread of those to the major organs. Now, on the LC16, it is up to 1 year. I think it's 1 to 17.
1 to 7. Okay.
Yeah.
Thank you. Dr. Braca, anything to add?
So just to add for the vaccine, so the MVB vaccine had been approved for adults, but we've also seen special conditions where the risk is high, outweighs the use outweighs the risk, or benefits outweigh the risk, like in outbreak settings. It has been recommended also to go down from 12 to 17 years of age. And we saw also the European Medicines Agency also issuing that recommendation. So MVA-BN can cover that period, 12 to 17 years of age.
Well, I think we will wrap up. We had two really outstanding talks. Wafa, did you have a question?
Yes, I had a quick question, and I'm wondering about the vaccination strategy.
Yeah,
I think it's quite diverse populations and very different risk behaviors and risk factors. And how are you, now that vaccine thankfully is arriving in the region, in the countries, how are you thinking of prioritizing the different subsets of the population for vaccination? Thank you.
Yes, thank you very much, Wafa. I think with WHO, the IMST has reviewed the situation, the context, and also the limited availability of vaccines, and decided to go for targeted vaccination, which is district focus, with the main groups being the contacts. Then, apart from the contact, the most exposed, which are the healthcare workers. And then those that are immunosuppressed, like people living with HIV, and also people that are exposed, like the IDPs, the refugees, And for the sexual transmission in particular, people at high risk like the truck drivers, it is really a targeted vaccination strategy. The problem also we're looking at is that, okay, for the contact, it is a post-exposure kind of vaccination. With the effectiveness of that is 20 to 30%. But it's more the other groups where you have pre-exposure prophylaxis where we can then expect the maximum benefit of the vaccines with the 82% effectiveness with the 2 doses. I think that is the current strategy that is being discussed with the countries.
Excellent. Thank you. Thank you for giving such a complete and succinct answer. I think we will wrap up here. We've had a really excellent session. Thank you again to our 2 outstanding speakers. The recording and the slides will be posted on the website, so you can look for that later on. And thank you very much. Take care and have a good day.
Yeah, thank you very much for inviting us.
Okay.
Thank you.
Wonderful. Bye-bye.
Okay, bye.